Hello and welcome to Season 2, Episode 59 of the Physician Assistant Exam Review Podcast. This week we're going to be continuing with pulmonology, talking about pulmonary cancers. My name is Brian Wallace. I'm the host and creator here at physicianassistantexamreview.com. Over at the website, you can find all the notes, everything you want over there. Pretty easy to search or find the Blueprints tab on the Blueprint tab on the menu. I recently just switched around the site, so the menu is now at the bottom of the site. So if you look around a little bit, it's there. You will find it, and you can find all the past content there. I have been taking out some old content, the stuff that's crummy and from Season 1 that I wanted to remove so that you guys don't hear that stuff anymore. Because I'd like to think things have gotten better over time. Maybe you could be a better judge of that than I am, but I'd like to believe that indeed they have. This week, we're going to continue through our blueprint review of pulmonology, of the pulmonary system. We've been covering, I'm already stuttering through this. We've been covering infections and infectious disease, TB, pulmonary issues, pneumonia, that sort of thing. And this week, we're going to continue, and we're going to be talking about different cancers that affect the pulmonary system. You'll see what I mean in just a second, because I don't want to just say lung cancer. So we will get to it very, very, very shortly, and you'll see more clearly. This is always a topic that I struggled with, that I never really understood, and I never really got. I've told you before, pulmonology was not my favorite. I think on every exam, it's my lowest area on the test. So maybe my normal ways of looking through material and pulling out what's going to be on the exam aren't quite as effective. Who knows? Maybe they are. And maybe this will help you as you go through it. So today we're going to begin with our priming questions as always. And so let's go ahead and get started with those. Give me two main categories of lung cancer. Two main categories of lung cancer. What causes hoarseness in a lung cancer patient? What causes hoarseness in a lung cancer patient? Give three characteristics that might make you think a pulmonary nodule is malignant. Give three characteristics that might make you think a pulmonary nodule is malignant. All right, so we're going to start with lung cancers, although like I started to say before, lung cancers are not the only type of cancer that can be found in the lung, right? So I'll talk about one at the end that's slightly different, but for the bulk of what you need to know is about tissue from within the lungs that causes the problem, right? So a couple of generalized facts and information for lung cancer. It's the number one cause of cancer-related deaths. I think I read somewhere it's more than the second, third, and fourth place put together on a yearly basis. 85% of lung cancers are associated with smoking. Interesting that is that high a number. I knew it was high. I didn't realize it was that high. 85% are associated with smoking. Multiple exposure and exposure to other toxins increase risk. So this is important. This is multiple exposure. So pack year history, that sort of thing, increases your risk, but also exposure to other toxins. So asbestos is bad to get into your lungs, but it's really bad if you smoke and get it into your lungs. That dual exposure to multiple toxins really multiplies the effects of these things. The 5-year survival rate for lung cancer is about 15%. That's 15%. Lung cancers are normally broken up into two large categories, small cell and non-small cell. And this is, I think, part of what screwed me up. When we name things, the certain nomenclature, so it's always a problem for me if I don't totally get why we have that nomenclature or why it came about. And I think that was part of my issue here, especially throughout PA school. I just didn't get why this separation occurs. But anyway, those are our two major categories, small cell and non-small cell. Now, one other thing I want to point out here right at the beginning is all of these lung cancers that we're going to talk about have some similar characteristics. So, all of them, like we talked about last week with our infections, cough is going to be one of the presenting signs, right? They're going to have some similar characteristics just because they are masses within the lungs. That should be expected. So one of the things you can get, I'm going to run through a list of complications from lung cancer that are more like mass effect than they are from the specific type of cancer. So this is for all of these. So the complications include things like severe superior vena cava syndrome, which is the compression of the vena cava, which can cause swelling and headaches and that kind of stuff. You can get a PANCE tumor, which is a tumor at the apex of the lung causing shoulder pain and nerve injury. So either to the brachial plexus. You can get Horner syndrome, which is it's almost the look of when somebody has a stroke on one side of their face. You get ptosis on that side. The pupils don't dilate correctly, and they don't sweat on that side, and that's secondary to nerve damage from that tumor. You can get hoarseness from impingement of the recurrent laryngeal nerve. You can get lung effusions, and then carcinoid syndrome, which is flushing, diarrhea, and telangiectasias. See, look, I can pronounce something correctly. Telangiectasias. So that's carcinoid syndrome. So that's the complications that go along with lung cancer. So our first major category is small cell lung cancer, or Oates cell. Small cell lung cancer is our first major category. This makes up about 15% of all lung cancers, and this is your really aggressive type of lung cancer. It metastasizes very early, and it goes to the brain, the liver, the bones, the kidneys, and the adrenal glands. This is, as soon as it's discovered, is pretty much assumed to already be metastatic. Along with this, you can get a paraneoplastic syndrome, which is found in about 20% of patients. And this is the tumor cells produce certain hormones, including adrenocorticotropic hormone and antidiuretic hormone. This creates Cushing's syndrome, or a syndrome of inappropriate antidiuretic. So we covered that in other areas as a secondary problem for endocrine issues that you might want to consider, is this paraneoplastic syndrome. So you can get these small cell lung cancers that can produce these hormones and create a Cushing's syndrome, or create a syndrome of inappropriate antidiuretic hormone, where they're just producing that antidiuretic hormone, or they're just producing that adrenocorticotropic hormone from the lungs. But it has the same effect on the body as if it were being produced where it's supposed to be produced. So that's sort of a secondary issue, but one to keep in mind. It's just a kind of a weird thing that if you see it on an exam, it may be helpful to recognize. Clinical presentation, like I said, these are all going to be very, very similar. So this is not going to help you differentiate one from the other, but you should definitely be aware of them. So clinical presentation: weight loss, anorexia, cough, hemoptysis, and chest pain. Lab studies and physical exam findings, again, these are going to be pretty similar. So you can get an x-ray. Cytology of sputum is going to be more or less helpful for some of these types of cancers. You can do a bronchoscopy. You get a CAT scan here, and you'll see hilar and mediastinal abnormalities, and a PET scan in order to look for metastasis. You can do a thoracentesis. And then treatment. Our mainstay of treatment for all of these is going to be surgical resection, if it's possible. It may or may not be, depending on where the cancer is located, where the tumor is located. But also with small cell, it's because of that early metastasis, because of that very aggressive nature of it, surgical resection may not be possible or may not be helpful. You're going to incorporate chemo and radiation, and those are going to be your treatments here. Non-small cell lung cancers is our next big category, right? So this one contains some others, and I think that's part of where I used to get confused, was I didn't realize that, I don't know why, I just never put it together, that these other types of lung cancers all fell under the umbrella of non-small cell lung cancer. So squamous cell carcinoma, adenocarcinoma, and large cell carcinoma are all fall under the umbrella of non-small cell. And these in general are less aggressive than small cell carcinoma. That's not to say they're not aggressive. Some of them are, but not as bad as small cell. Squamous cell carcinoma is our first one. This is most commonly found in large central bronchi. And our clinical presentation here is going to be cough, chest pain, dyspnea, weight loss. And then the one you can sort of put a star next to, and I did in the notes, I made it bold, is hemoptysis. This is found in the large central bronchi, so you can get some bleeding and some blood in your cough because of the location of this mass. Again, our lab studies and physical exam findings will be pretty similar throughout. So you get X-ray, cytology of the sputum. Again, cytology here will work pretty well because it's in those large central bronchi, so you'll be able to see it, those cells more clearly and more evidence of it. Get a PET scan in order to look for metastasis. Thoracocentesis is possible. And again, surgical treatment here is going to be resection, if possible, radiation, and chemo. Adenocarcinoma is next, our second lung cancer found under the umbrella of non-small cell lung cancer. And this is the most common lung cancer in non-smokers. The most common cancer in non-smokers. And this is typically found in the peripheral lung, And usually these also have metastasized on presentation. So these are relatively aggressive. Here, our patients have fewer symptoms, and that has to do with the location of the disease. And it also is the reason why they are more likely to have metastasized on presentation, because the symptoms aren't as strong. Labs and studies are going to be the same: X-ray, cytology of sputum, although that won't work as well, again, because of the location of that tumor. On the CT, you may see a peripheral mass, and the PET scan in order to look for metastasis. And then again, surgical resection is best treatment, but once they come in and you've seen that they have that metastasis, it may not be helpful. Radiation and chemo may also be used. Next, we move on to large cell, which again falls under the umbrella of non-small cell lung cancer. Non-small cell lung cancer. Large cell is one of those. And this is something else I didn't get at the time, but large cell is basically a bucket for the other stuff we don't identify as smoothly. So there's several different types of cancer that kind of fall into this area, and they're bigger cells, and they have a couple of different similar characteristics, so they call them large cell lung cancer. So this also can have early metastasis. The clinical presentation here is a weight loss and a non-productive cough, and similar to the others. We're going to look this over and work it up pretty much exactly the same way, because again, we're not going to know ahead of time which one it is. So when someone comes in with these symptoms or these problems, the workup is the same. The treatment, one more time, is surgical resection, radiation, and chemotherapy. So that's our pure lung cancers. Next, we have carcinoid tumors. These are neuroendocrine tumors most commonly found in the midgut, but can also originate in the lungs. Most have benign features and are symptomatic. Clinical presentations. Symptoms are due to the excess hormone production. So these are creating, similar to our small cell cancer, these are creating excess hormones, or they're producing excess hormones within the body. And that's where the problems come from. So not from our mass effect, not from metastasis, none of that stuff in this case, just from the fact that they're just producing this excess hormone. So you can get flushing, diarrhea, abdominal cramping, edema, and then specific to the carcinoids of the lungs, you can get cough and hemoptysis. Again, a CT, MRI, bronchoscopy, cytology, all of those same things would be how you work this up. And then a surgical resection of the tumor is how you'd go about treating it. The last thing I want to cover for today is pulmonary nodules. So this is largely an incidental finding on an exam. You get a chest x-ray for some reason, and you see what you believe to be a mass. And it's, what do you do next, right? Because lung masses are scary. That's just kind of just the way things work. So a pulmonary nodule less than 3 centimeters and no other lung findings is usually not an issue. Most commonly, these are granulomas from an old infection, like we talked about in the last episode. Cancer is rare, and especially rare in patients under the age of 30. So and this is kind of the thing I want to point out, like I've been doing on the last couple of shows, is they're not going to write you a question that says, hey, you see a pulmonary nodule in a 18-year-old female. It just seems very unlikely, and that's going to turn out to be cancer. They may ask you to work it up. They may ask you to say what you think it is, but it's unlikely that's going to be cancer on your test. It doesn't mean it's not possible. It's certainly possible, but we're going to stay away from those crazy edge cases and stick with the majority of the time. Cancer is rare in patients under 30 in a finding of pulmonary nodule. Just is unlikely. Keep that in mind as you move through your exam. Lab studies and physical exam findings. So one key for working at pulmonary nodules, you always want to compare previous studies to determine the rate of growth. Size of the mass is important, but the rate of growth is one of the most important things. You're going to monitor with a CAT scan. So there are nodules you will follow and not do anything about. Those are going to get CAT scans every few months for the first 3 years and follow like that. And you're monitoring for rate of growth. Increasing size is directly correlated to the risk of malignancy. Some bad adjectives for the description of the nodule on an X-ray or a CAT scan would be spiculated, eccentric calcifications, thickened walls, those sort of things. You may want to get a biopsy or do a bronchoscopy. Treatment here can either be watchful waiting or surgical resection, depending on the likelihood that this is cancerous. Now, if you can get at it, you can do a biopsy, then you can find out. But if you have a young person, or I think it was something like 40-50% of them turn out to be granulomas from previous infections. See, there's a lot of possibilities here other than cancer, although obviously that's the big fear. So watchful waiting is a reasonable answer in the correct patient with those serial CAT scans, and you're watching for any growth. But then certainly surgical resection or lobectomy if necessary. Okay, so that brings us to the end of pulmonary neoplasms and that section of the blueprint, which is good because that means we're just about done with pulmonology. We'll have, I think, one more episode on pulmonology where we just kind of wrap up all the leftover categories for pulmonology. Anything that didn't fit in the blueprint, they sort of throw at the end in an other category, and we'll hit that. So let's go through real quick before we wrap up for today. I have a couple things I want to talk about, but first let's talk about our study tip for today. All right, so something I don't think I've talked about on the show in a long time, I talk about constantly in the Physician Assistant Exam Scholars newsletter, but I don't think I hit it much here, is the idea of active versus passive studying. And this is a huge one. This is something, like I said, I just all the time in the emails and in the newsletter, I push on this button because I think it's one of the most important things you can use to improve your game. The simplest thing that takes up less time will absolutely boost your scores, make your attention go through the roof, all those things, is to stop spending so much time studying passively and spend more time studying actively. Just real quick, because I'm not going to spend a ton of time on it here, but passive studying is sitting in lectures. It's reading your notes. It's reading through books. It's stuff to get information into your brain. It's stuff to make you think a little bit as you see new information. And it's absolutely necessary because there's no other way to get new information into your brain than through passive studying. The problem comes in when we think we read all night, so we should remember something. And the answer to that is absolutely not. You obviously know at this point how difficult it is to remember things that you've only read. So that's where the active part comes in. You have to force your brain to do some work. You have to force your brain to process the information for it to really stick. So there's lots of different ways to do active studying. Answering test questions is one. I talk about that a lot in the emails. A couple others would be things like presenting stuff to your class, presenting stuff to small groups. Teaching the material is always a good source of active studying, active learning. Creating worksheets, creating mnemonics, not necessarily studying the mnemonics, but creating the mnemonics. Those are the things that are active studying. Those are the things that really help. So I can't encourage that enough. And like I said, I spend a lot of time in the newsletter going through that, and a lot of time, and even in the emails, going through how important that is. Speaking of which, if you haven't signed up yet for the emails, definitely head over to the website, www.physicianassistantexamreview.com. And actually, while we're on the topic of active versus passive, I wrote the book, The Final Step, which is 1,200 questions, keyword questions for getting ready for the exam. Actually, I had someone just buy it today and send me an email. How quick does it come? I'm taking my exam in a couple days and I really need the book to get here quick. And it does, it's shipped to UPS. So it takes a couple of days, 1 to 3 days, something like that. But that's exactly what it should be used for, or for before end-of-rotations exam. People have told me they've used it for our medicine exams. It's not for that passive setting. It's not to sit and read. It's quick questions to run through as fast as possible and process them and force your brain into working. And I lost track of where I was here. Either way. Oh, I know what the point was. So when you go over to the website and you sign up for the email list, which is I send out daily emails on all kinds of stuff that's going to help you get better at this whole being a PA student, being a exam taker, all that stuff, help you get better at all those things. But the important part here that I want to point out is you will receive the cardiology chapter of that book, The Final Step, when you sign up for the email list. And that's got, I think a couple hundred questions on cardiology alone. And for one thing, it's awesome because you can take that and absolutely use it for the cardiology section, but then you can get a feel for if you like the book or not and get an idea for how that works. So anyway, head on over to the website, check out the emails. I think you will be thrilled with the information that comes through there. It's a ton of fun for me to write it. I get great feedback on it, but then also you'll get the cardiology chapter of The Final Step and get to take a look at those questions and use that as you see fit to pass your exams. So anyway, we'll finish up the active versus passive conversation there and move on to answering our priming questions. 2 main categories of lung cancer. Hopefully I hit on this hard enough throughout that you have the answer here. 2 main categories of lung cancer would be small cell and non-small cell. I think if they named it something different, I would remember it better. I don't know. For some reason, that just never felt right. What causes hoarseness in lung cancer patients? What causes hoarseness in lung cancer patients? Pressure on the recurrent laryngeal nerve. And give 3 characteristics that might make you think a pulmonary nodule is malignant. Give 3 characteristics that might make you think a pulmonary nodule is malignant. A patient who's a little bit older, say 45 or older, indistinct margins, and rapid growth. Those 3 would certainly point me on a test question to think that a pulmonary nodule should definitely get worked up a little bit further. So anyway, that will take us out today, take us to the end of lung cancers. I can't wait to finish up pulmonology and move on to something else exciting. Oh, speaking of exciting, we did have our winner for our grand prize drawing last week. I have not been able to get in touch with the 2 runners-up yet. So if you signed up for that and you haven't been checking your email, check your email, because I'm going to be forced to pick 2 new runners-up very soon. But the person who won, super excited. I'll share information about that a little bit later, especially through the email list, and give you some info on them. Very, very exciting. Thank you to everyone who signed up. And I guess that's the end of the music. So that's going to take us out for today. Until next time, good luck. And I can't wait to talk to you again. Take care.